Should launch the session. It's December the 17th, 1 o'clock Central Time US. I'd like to welcome everyone to this very unique session today. One of the hallmarks of our webinar series is to seek out all opportunities to bring together individuals who have an interest in neonatal hemodynamics with our colleague experts in pediatric cardiology. And, as all of you know, there is a very strong overlap in all of these domains. And as time goes on, we start to recognize, even more so some of the nuances that fall between the cracks that really, foster more and more collaborations. So this session today, we're very fortunate to have some tremendous speakers, panelists from the world of, pediatric cardiology. And I think this hopefully will be a session that will be rewarding to all of you. First thing I would like to do is to introduce Dr. Fate Zhu, who is an assistant professor of pediatrics at the University of Toronto, a neonatologist at Mount Sinai Hospital, and a neonatal hemodynamics clinician stroke scientist. We're very fortunate to have Fate not only be co-moderator today, but she has taken over the role of working with me and planning these sessions. So you're going to hear a lot more from her and see her a lot more over the coming months, hopefully 2 years. Fate has a particular interest in the interface between neonatal hemodynamics, echocardiography, and AI. And I would just point out to each of you that the February session, we're going to have a very unique special session on AI and neonatal hemodynamics stroke echocardiography that will bring together a whole series of experts who are engaging in the science of AI and echocardiography, which is increasingly important and certainly will be our future. So without further ado, I will hand it over to Fate. This is a unique session in that our speaker is not live. She is currently in Bangkok. So for the first time, we have a recorded session. So hopefully we will have no glitches from that perspective. Fate, the floor is yours.
Thank you. Yeah, thanks, Patrick. So total honor to be here to introduce our speaker and our panelists. So like what Patrick said, our speaker, Dr. Lindsay Freud, is currently in Bangkok, but she is the section head of fetal cardiology and an associate professor of pediatrics here at the University of Toronto, and her research centers on the understanding the natural history of heart disease in utero and investigating percutaneous and pharmacological therapies to improve the outcomes of these babies. And we have on our panelists, we have Dr. Amanda Hauck. She is the director of the pulmonary hypertension program and also a pediatric cardiologist over at the Lurie Children's Hospital in Chicago. We're also joined by Dr. Shaine Morris, who's the director of fetal cardiac intervention team and the medical director of the cardiovascular genetics program at Texas Children's Hospital. And also Dr. Rachael Hyland, who's the director of ECMO in the NICU at the University of Iowa Said Family Children's Hospital. So a wonderful panel of people for our discussion later. And Laura will set up the recorded talk from Dr. Freud.
Good afternoon, and thank you to Patrick and the organizers for inviting me to give this talk. I apologize that I can't be with you live this afternoon, but I will leave my contact information at the end, and I'd be happy to follow up with any questions or discussions. So the title for the talk that I was given was High-Risk Hemodynamic States in the Fetus and Interventions. And I hope it's okay, but I changed the title slightly to make it a little more nuanced in that we're going to be talking about fetal cardiac therapy for high-risk states in the perinatal period. And whenever we're talking about fetal therapy, whether it's fetal cardiac therapy or other types, I think it's important to remind ourselves of some of the guiding ethical principles that are involved. And this is an example from a paper from over 15 years ago now from the International Fetal Medicine and Surgery Society, but I think it's a very important construct for us to think about. So one is that the natural history that we're thinking about intervening upon in the fetus should be well understood. The condition should be lethal or with severe morbidity if not treated in utero, and the fetal intervention should be at least partly corrective. So when we talk about fetal cardiac therapy in particular, we're talking about several potential opportunities to intervene on the developing baby. And what I like to say is that it really comes in many flavors. The first are medications to the mother that then pass through the placenta and affect the fetus. So that's also known as transplacental therapy. The second category is percutaneous minimally invasive intervention. So you're utilizing catheter-based equipment in order to intervene directly on the fetal heart. And then the third is open fetal surgery, in which the uterus is externalized and the fetus is operated on directly. And so what I'm going to do for the purposes of this talk is to discuss one in each of these categories, just to give you a sense of what the possible opportunities are and where things may evolve in the future. So starting with transplacental therapy, I'm going to talk about it in the context of Epstein anomaly and tricuspid valve dysplasia. Now, these two entities are often linked together because even though they're very different malformations of the tricuspid valve in terms of how it develops, they both often produce severe tricuspid regurgitation in the fetus. And this ends up being a very poorly tolerated condition in the developing baby. They end up with huge hearts, often with hemodynamic deterioration and fluid collections, hydrops, and demise in a select few of them. About 10 years ago, we had looked at almost 250 fetuses across 23 North American centers. And when we looked at those who either had a fetal demise or survived to live birth but did not make it home from the hospital alive, we saw that there was 45% perinatal mortality, which is really one of the highest perinatal mortality rates of any diseases that we care for in the current era. So why exactly does this happen? Well, I think it's important to take a step back and remind ourselves of the pathophysiology and the role of the duct. In the context of a fetus with severe Epstein's or tricuspid valve dysplasia, there will be a lot of tricuspid regurgitation, but there may still be antegrade flow across the pulmonary vascular bed with normal intrauterine right to left shunting at the level of the duct. And that's a favorable condition and one in which we would expect both the fetus and the live-born neonate to tolerate the circulation fairly well. In about 20% of these fetuses, there is anatomic right ventricular outflow tract obstruction. And in these cases, there is reversal of normal intrauterine ductal flow to be left to right in order to perfuse the fetal pulmonary vascular bed, which is, of course, adaptive and physiologic. The problem arises when there starts to be left to right shunting at the ductal level, but without anatomic right ventricular outflow tract obstruction. And this is an entity known as functional pulmonary atresia, which arises essentially because there's so much regurgitation through the tricuspid valve that there isn't enough antegrade ejection. And this often will occur in the setting of a failing right ventricle that's unable to generate a significant amount of pressure. And when this happens, you can get pulmonary regurgitation. And this pulmonary regurgitation completes what is known as the circle of death, or this very dangerous cascade known as circular shunting. And essentially what happens is the blood is going around and around and around in the fetal heart and stealing from both the systemic as well as the cerebral circulation, which is a topic I'll return to. And the end result is diminished end organ perfusion, acidosis, and demise or death. And so what is the transplacental fetal medical intervention that may be useful in this circumstance? Well, we know that in general, pregnant women are advised not to take NSAIDs, nonsteroidal anti-inflammatory drugs, because it causes constriction or even closure of the ductus arteriosus. But in this case, the ductus arteriosus is a critical part of that circular shunt. So if we were to give NSAIDs to the mother of a fetus that is evolving to have high drops in the context of significant circular shunting, can we stabilize those fetal hemodynamics and permit a delivery closer to term? And so really this is the concept map as we think about NSAIDs. It's certainly not curative, but the hope is that we can improve fetal hemodynamics, prolong gestation to produce a live birth closer to term, and thereby improve survival. And so what does this look like in real life? Well, here's an example of a fetal echo at almost 32 weeks gestation, and you can see there is severe tricuspid insufficiency in the context of an overall dilated heart within the fetal chest. When we Doppler the tricuspid regurgitant jet, we see that it's very low for an almost 32-week fetus at about 14 millimeters of mercury, and this is suggestive of a failing right ventricle. So when we look at the ductus arteriosus flow, we see that it's reversed, left to right. And then when we look at the right ventricular outflow tract, we can see that there's severe pulmonary regurgitation consistent with significant circular shunting. So the way that I always teach fetal echo to fellows, and especially when we're thinking about applications of fetal cardiac therapy, we want to understand how this is affecting the rest of the fetus's circulation. And when you look at the extracardiac Dopplers, which I term the fetal vital signs, you can see that from the umbilical artery to the middle cerebral artery, the ductus venosus, and the umbilical vein, there are all very abnormal blood flow patterns. So this is a fetus in distress. So if you give NSAIDs and produce what we were able to produce here, which is significant ductal constriction, you can see this, which is a significant improvement globally in the extracardiac Dopplers, not complete normalization, but significant improvement. And this is ideally what we like to see in fetuses that respond to NSAIDs with ductal constriction. So what does this look like in a larger group of patients? Well, a couple of years ago, we reported the experience of 21 mothers who were offered NSAID therapy at 10 centers. And if you look at those mothers who consented and whose fetuses achieved ductal constriction, you can see that almost all of them made it to live birth, as compared to those who declined or in whom constriction was not achieved. And in those, less than half made it to live birth. And this difference was statistically significant. Now, I certainly don't have to tell a group of neonatologists that beyond just survival to live birth, we want to know how mature were they when they were live born. And you can see that those that were successfully treated were born at over 36 weeks gestational age versus those who were not, 33 weeks. And this was, in fact, also statistically significant, but most importantly, as we know, very, very clinically important. Now, I want to also talk about another interesting and important therapeutic gain that may be achieved by using NSAIDs in this population, which is not just improving their survival, but also potentially improving their neurodevelopment. As I showed you earlier when we were talking about the general pathophysiology, and as you saw those markers in the middle cerebral artery, fetal cardiac MRI is a tool that enables us to quantify how much blood flow is going to the brain. And what you can see here demonstrated in these cartoon diagrams is you have Epstein anomaly without circular shunting and Epstein anomaly with circular shunting. And in addition to very important differences in the amount of systemic perfusion by looking at the cardiac output in the descending aorta, you can also see that there is dramatic differences in the cardiac output, the percent cardiac output going to the brain, as demonstrated by that returning from the superior vena cava. 34 in the Epstein without circular shunting, versus half, 17, in those with circular shunting. And by constricting the ductus arteriosus and significantly decreasing the amount of flow going through that ineffective circular shunt, in this case from 42% to 10% of the fetal cardiac output, you see dramatic improvements not only in the descending aortic flow, so in systemic perfusion of the fetus, but also significant improvement in the cerebral circulation. And again, demonstrated here, if we look at fetuses that have no fetal cardiac disease versus those that have Ebstein's but without a circular shunt, and finally in those with a circular shunt, you see progressive losses in cerebral volume, which is likely attributed again to that low flow state due to the circular shunt. So we also know that lower fetal brain weights are associated with neurodevelopmental delay. So the idea here is that NSAIDs will not only stabilize the fetal circulation to improve survival, but may also consistently improve fetal cerebral blood flow and therefore neurodevelopment in a subset of fetuses. And so given this experience, which has been anecdotal, retrospective, we decided to embark on a much larger adventure housed at Sick Kids, which is the Fetal Ebstein Anomaly and Tricuspid Valve Dysplasia Registry, or FEAT Registry. We're fortunate to have 41 sites on 4 continents that are participating, and we are prospectively enrolling fetuses, whether or not they are offered NSAIDs, receive NSAIDs, respond to NSAIDs, to try and again refine the natural history of this disease and monitor what happens with fetal NSAIDs in terms of safety, efficacy, survival, and neurodevelopment. And so the idea behind looking at this fetal registry is that in addition to, of course, following their fetal and neonatal outcomes very carefully, we're going to continue to follow these patients for as long as possible to assess their neurodevelopment and their quality of life. And I'd like to mention that this is a registry, so we're happy to have other sites involved, ideally for prospective enrollment, but also for retrospective enrollment. So I'll include my contact information at the end of the talk in case you or your site might be interested in joining this effort. And I'm going to conclude talking about transplacental fetal cardiac therapy by mentioning that this is, of course, the one that I'm most interested in studying, but there are an evolving number of select indications for which fetal cardiac therapy delivered transplacentally may be useful. But these are rare diseases, so multi-center collaboration, working together to understand the efficacy of this therapy and outcomes are essential. And of course, we need to follow these children long-term to make sure that we are doing the right thing. So I'm going to move on to the next topic, which is percutaneous minimally invasive intervention. And there are a variety of interventions. Again, this is utilizing catheter-based equipment, entering directly through the maternal abdomen to directly affect the fetal heart. And while there are a number, I chose to focus on hypoplastic left heart syndrome with a highly restrictive or intact atrial septum, partly because there is some new data available for this particular form of fetal cardiac intervention. So again, we're talking about established HLHS, established single ventricle disease, not preventing single ventricle disease, which is the purpose of fetal aortic and sometimes pulmonary valvuloplasty. And this disease is very important because it's associated with very high mortality. Essentially, what happens is that the pulmonary vein blood flow, as it returns to the left atrium, it obviously doesn't have a way to go through the left heart, but in a subgroup of patients, it also doesn't have a way to decompress through the foramen ovale with left to right shunting. And as a result, the left atrium becomes very pressurized, and there ends up being a lot of backflow into the fetal pulmonary bed. And this can cause both fetal pulmonary and parenchymal damage. And of course, we know that we're not going to be able to complete staged single ventricle palliation in the context of unhealthy lungs. Now, postnatally, if there is no pulmonary vein egress, then of course there will be profound cyanosis, acidosis, and death, as there is no way for that oxygen-rich blood flow from the pulmonary veins to enter the systemic circulation. So when we look at outcomes of single ventricle heart disease following prenatal diagnosis, we see in fact that those with this version of hypoplastic left heart syndrome that are deemed high risk have significantly worse survival from the time of prenatal diagnosis compared to those that don't. And in fact, it's only 40% transplant-free survival at 2 years of age. So in fact, again, quite a significant disease. So what does this look like? This is a fetus from our institution at just over 27 weeks. And what you can see here is established HLHS. So you have this left ventricle, which is not contracting at all. And then you have the single right ventricle here, reasonably sized, both right atrium and left atrium. When we add color flow here, you can see that there is no color flow across the atrial septum, consistent with an intact atrial septum. And you can also appreciate that the pulmonary vein, which is coming in here, is quite dilated with to and fro flow. Of course, we always corroborate these findings with Dopplers. And so here you can see what's happening in the pulmonary vein Doppler. And you can see that there's really to and fro flow consistent with left atrial hypertension and basically a lot of that pulmonary blood flow going back into those lungs, which can cause that damage to the lungs over time. And we recently looked at our experience of our fetuses with hypoplastic left heart syndrome with a highly restrictive or intact atrial septum. We looked at how their atria look, how their lungs look, and of course, outcomes. And so what we saw is that very highly correlative are concerning pulmonary vein Doppler findings with this degree of pulmonary damage in the lungs, which we call pulmonary lymphangiectasia on fetal MRI. And this is important because we know that many centers across the world do not have the ability to do fetal MRI. But here we're showing that it correlates very nicely. So what can we do to either improve the fetal lung condition or thwart further damage to the fetal lungs throughout the course of gestation? Well, that's what we're trying to do here by opening up the atrial septum. And of course, by not only improving lung health over the course of gestation, we're also producing a more stable neonate at the time of birth. So here you can see that the catheter-based equipment is already across the fetal chest into the fetal heart, and you can see here that a stent on a balloon is ready to be opened and released across the atrial septum in this fetus. This is after we've removed all of the catheter-based equipment, and you can see that there is now a stent that is in the atrial septum with left to right flow, now decompressing that left atrium, decompressing the fetal pulmonary vascular bed, and you can already see that the pulmonary veins are not as dilated. And when we go to add pulmonary veins, Dopplers to them, you see that there's a significant improvement in mostly forward flow across the pulmonary veins and not necessarily just that back and forth to and fro flow. So when we looked at our experience and you compare the fetuses that did not have an intervention, which are demonstrated in orange, and you compare those to those that did have fetal interventions, which are represented in green, you can see that there's a significant improvement in forward flow through the pulmonary veins compared to those that did not have an intervention. And what we showed, and also the group from Texas showed, and I'll be returning to talk about their work, is that coincident with this improvement in the pulmonary vein Dopplers are also improvement in the pulmonary lymphangiectasia, which is one of our goals of fetal intervention for the disease. And here you can see that being shown in this image, which is from the paper from our Texas Children's colleagues. This is a fetus prior to intervention at 28 weeks, an improvement in the lungs, although still not normal fetal lung appearance by any means, but improved by 35 weeks gestation. So what about the outcomes in terms of not just improvements in what we're doing in utero, but about what happens after birth? And are we seeing that a greater percentage of these newborns survive to neonatal hospital discharge? So first, I'm going to show you some data from the International Fetal Cardiac Intervention Registry, which is a multinational cohort, includes data from our hospital, Sick Kids in Toronto, amongst others. And in this paper from 10 years ago, there were 24 technically successful procedures, which was 67% of those attempted, and 12 technically unsuccessful. There was also a 14% risk of fetal demise. Another important point. Now, when you look at survival to neonatal hospital discharge, you can see that there was 63% survival to neonatal hospital discharge in those with a technically successful intervention versus 44% in those that were technically unsuccessful. And while these numbers seem very important to us, this wasn't actually statistically significant, likely due to very small numbers, nevertheless hopeful in what could be accomplished in more fetuses undergoing technically successful interventions. So with that, I'm going to talk about another recent paper, a very important paper from the Texas group. And they described their experience in examining 60 fetuses with hypoplastic left heart syndrome and intact atrial septum, of which 18 were considered too high risk and excluded off the bat. Of the 42 that underwent intervention, 25 were technically successful. So we arrive at a very similar rate of technical success even 10 years later, and from a large and experienced center of 72%. And in their series, the fetal demise rate was unchanged at 14%, which just behooves us to recognize that this is a very high-risk population and a high-risk intervention. When they looked at survival and stratified it by those that underwent fetal atrial septal intervention versus those that didn't, and I'm including the numbers here because much of this becomes a numbers game when you're talking about small populations of 25 versus 17. There was no statistically significant improvement in survival, but you can see that those Kaplan-Meier curves certainly look quite different. So when you group them slightly differently and you look at technically successful fetal atrial septal interventions versus those that did not have or had a technically unsuccessful intervention, then your groups become 18 and 24. And in fact, this was statistically significant in addition to clinically meaningful. I also want to mention that in the no or unsuccessful, particularly the unsuccessful fetal atrial septal interventions, includes 5 procedure-related fetal demises. And so with that, my conclusions, and we do perform these interventions at SickKids in Toronto, but we are the only site to do so in Canada, is that the findings are very meaningful, but in select fetuses who meet strict candidacy criteria, which we didn't have a ton of time to talk about for the purposes of this talk, but also that have and survive a technically successful intervention. And so I think this underscores having centers of expertise and also the nuances of pre-intervention counseling for those of us who have to walk families through what is the likelihood of a successful intervention and what is the likelihood that their baby survives a technically successful intervention. So again, promising data in very select group of patients undergoing a high-risk procedure. I'm going to now discuss open fetal cardiac surgery. And to discuss this topic, I'm going to show this paper from the CHOP group by Rachael et al. That was published 9 years ago, in which they described their experience with fetal intrapericardial teratomas. These are a very, very high-risk tumor that we sometimes see in fetal life because they tend to cause massive pericardial effusions, high drops, and again, demise. A common theme here being when we're talking about fetal cardiac therapy in the first place is that these are all very high-risk conditions with poor survival. Now, in this series of 8, the fetus that gets the most attention is fetus number 4, who at 24 weeks underwent a successful open fetal cardiac surgery to remove the pericardial teratoma and survived and had an encouraging postnatal outcome. So what exactly does this look like? Well, this is something that we have also embarked upon in our center. So this is the fetal echo of a child at 24 weeks. And what you can see here in this sweep is that as we're sweeping through, it's a structurally normal heart, but as we sweep superiorly near the right atrium and as you approach the mediastinal vessels, you see this very heterogeneous tumor. And of course, you can't miss the fact that there are multiple fluid collections here, pericardial, pleural, as well as ascites, consistent with high drops in this particular fetus. When you add color, it can be helpful because it really helps you perceive exactly where this tumor is located. And because of the severely hydropic nature of this fetus and the preferences of the family, we did, in fact, ultimately offer them open fetal cardiac surgery. And this is done, of course, with colleagues that are expert at this from their experience with fetal myelomeningocele. And here you can see that the mother's uterus has been externalized and has been opened. Here is the fetus. As soon as the fetus has its arm out, we take one of our very experienced NICU nurses in order to place an IV to provide the fetus directly with anesthesia. And then here is the sternotomy, and here is our surgeon who is extracting this tumor, very heterogeneous, bulky tumor on the surface of the pericardium. And these are some of the final videos where you can see that the tumor has been removed, and you can see the fetus's heart, which looks actually really quite healthy and is beating normally prior to closing the chest and placing the uterus back in the mother's abdomen. So this was a very technically successful intervention, and you can see here at 29 weeks how beautiful the fetal echo looks. There's no residual tumor, as well as no residual fluid collections. Unfortunately, approximately a week after this fetal echo, the fetus had a sudden and unexpected demise that we were really never able to uncover a clear etiology for that demise. And I think that I mention this case because it's important to really carefully think about what we're doing and put this in the context of what other centers have done and what is the best going forward for not only high-risk fetuses, but for probably otherwise healthy mothers. And so this was a systematic review that came out back in 2017. And when you look at this, there is included several fetuses who underwent open fetal cardiac surgery from large centers, UCSF, Baylor, Texas Children's, and inclusive of the one from CHOP that I mentioned earlier. And you can see that there was neonatal death, fetal demise in 2 of the experiences. In the CHOP experience, there was a successful case, but a significant complication of a subsequent pregnancy due to uterine rupture from that large uterine incision. And so at least my conclusion for the time being is that in terms of open fetal cardiac surgery, I'm not sure that we have a clear indication with a proven track record of success, particularly when we take into account the significant morbidity to the mother. So even though she may do very well during the index pregnancy, she has very high risk subsequent pregnancies. And when I reviewed the literature to see if there have been any additional case reports of successful open fetal cardiac surgery for this indication, I didn't find any. But there are increasing case reports of successful exit procedures that are being done earlier and earlier, as early as 28 weeks, which was reported by a couple of groups. And so we will see how this area also unfolds. So with that, I am going to thank you for your attention. Again, here's my contact information in case there are questions that arise from this talk or opportunities for discussion, and of course, opportunities for collaboration. So I want to provide again, not only my email, but the email for the FET registry. If you or your center would like to be involved to help us really understand NSAID therapy or just overall outcomes for that severe cohort of diseases. So thank you again, and I hope you have a wonderful panel following this.
Okay. Powerful talk, not necessarily something that we spend a lot of time thinking about in the NICU world, but a lot of the concepts may have direct correlation to what we do. We should invite our other panelists to the stage. Thank you all for joining. So, Faith, I'll hand it over to you.
Yeah, I think that was a really wonderful talk by Dr. Freud. Very interesting data that she showed, I think, from the Texas group about the hypoplastic left heart atrial surgery. Talked a lot about survival, but I wonder maybe, Shaine, you could talk a little bit more about sort of the post-delivery, what that course maybe looked like, if something you were familiar with, and whether that sort of maybe impacts the type of surgery or type of repair that these babies had.
Yeah, absolutely. So, this is something, that paper was just published by us a little bit earlier in 2025. For the paper originally by the International Fetal Cardiac Intervention Group, that was the collaborative paper that she mentioned, did not improve survival. That paper actually showed that patients who got an intervention were less likely to need an emergent resuscitation and less likely to need a cesarean section delivery. So we knew that you could have kind of a more stable delivery, but it didn't show survival differences. Now, when it came to our center, definitely the stability at birth was different. So looking at different things, if we look at the gestational age, that wasn't different. If you looked at cesarean, it was a little mixed because we compared babies in which we were unsuccessful or never had an intervention to babies who got a successful intervention. And the challenge is, if you were about 80% of our babies had lymphangiectasia. So the babies that had an unsuccessful intervention or did not have an intervention often chose palliative care because there was nothing. Often centers we did not offer surgery, or the parents didn't want to go through surgery because the outcomes are horrible if you don't do a fetal intervention. And so a lot of them elected not to have a cesarean because they were not trying to resuscitate the baby. So we actually didn't have a difference in cesarean versus vaginal delivery in our group because a lot of them were electing palliative care. But if we looked at emergent interventions, there was definitely a significant difference between emergent atrial septal interventions. And then right in the postnatal period is different. So I just will compare the two most common pathways. If you're born with a severely restrictive or intact septum, you will usually get sick within 2 hours of birth. So those kids, we are doing exit to ECMO, or we're having the cath lab in the delivery room, or we're rushing to the OR. Here we would rush to the cath lab to get the atrial septum open, usually while being hypoxemic, sitting in the 50s, and have very poor long-term outcomes. And that's what we saw. Again, we only had 20% survival, but the ones who did survive went through that. In our cohort, what happens if you have a successful atrial septal intervention? Most of the stents stay patent. So they typically are born very stable. We typically do a vaginal delivery unless it's a repeat C-section. But they do have this funny thing, and actually you guys will understand because I think it's very much like an atrial septal defect in an RDS baby, that we are now have abnormal lungs, but they overcirculate. So if we don't intervene, they get high PVR. But when we've done a stent, they've had time for the lungs to relax. So once they're born, their PVR starts dropping. They start overcirculating, and they have these bad lungs. So they get really tachypnic within 6 to 24 hours. And it's tricky because people are used to tachypnea in this hemodynamic state being a restricted septum. So we find our ICU always want to go open the septum, because sometimes on echo it'll look restrictive, but their sats will be 89% because they're actually over-circulated. And we've made a third physiology. Typically hypoplastic left heart is very well balanced. If you have restrictive septum, you have this pulmonary venous congestion physiology, but we've now created this rapidly over-circulated physiology. And so we actually have to do is band them pretty quickly. So these kids, this new group of patients with a successful atrial septal intervention, we often have to do either an early Norwood or open the septum and do bands, but you can't just open the septum. We did that for one patient and we got a 7-to-1 QPQS because that's the whole cardiac output going across the atrial septum, right? And so we have recognized some patients are stable, but it is really common to get really tachypnic fast, and then we need to band them, and then we'll open the septum at the same time. So it has created a different physiology, and we have to, as we get new people in the ICU who don't work at other institutions, we have to remind people of that.
Shaine, can I just go back to the what Lindsay talked about with the functional pulmonary atresia and the use of non-steroidals, just for a moment. I got two questions here, and I'm going to actually pivot to Rachael to talk about some of what we see in the postnatal state. But how common is this practice? Okay, outside of the sick kids group, is this something that's broadly applied? And then the other question I would have is, on the counter, we have other animal data, fetal data, and actually some human correlates raising concern about non-steroidals and the pulmonary vascular bed and remodeling and so forth. And, how do we get the balance right between closing the duct closes and the pulmonary vascular bed then is totally messed up versus, you apply to these mothers and how do you monitor them and so forth. So anyway, it's a lot of questions in one there, but I'm very, very curious to know, is this something you guys do in Texas? And what are the potential caveats to it?
Sure. So, the pulmonary atresia, Epstein's with functional pulmonary atresia and pulmonary regurgitation, when you have the circular shunt, this is about the worst fetal disease we can have. It has over 50% mortality by either prenatally or by 30 days of life. And we all are desperate to do something about it. We definitely have used steroids. It is very, very tricky. We're one of the collaborators on Lindsay's papers, but we have definitely had complications both ways. So we have had non-responders where we kept upping the dose. And then we caused oligemia from the fetus. And actually one fetus had anuria at birth and ultimately wasn't offered palliation because they had complete renal failure that we probably induced by the endomethacin, even though we were able to extend that baby's life and get the cardiac circulation. So we've had that complication. And then we did what you mentioned. I think there's only been 2 case reports, one from Toronto and one from us, where we did use a low dose Indocin and then they responded right away. And we had it on a few days. The high drops resolved, all the Dopplers got better, the baby looked great. We took the Indocin off and the duct completely closed. And this was fairly early. We were around 27 weeks and, the baby was delivered around 35 weeks and basically developed no more pulmonary architecture. Like the PAs were very small. There was multiple collaterals and that patient was inoperative because we could not, there was not sufficient pulmonary circulation. So it is this really delicate balance, but most patients that we're going to treat, 50%, just Epstein's anomaly is 50% mortality. If you already have a circular shunt, it's like 70, 80% mortality. So we're kind of desperate to do something. So I know there's a long answer, but yes, we try Indocin, but it is a careful dance because you can definitely have complications from the meds. In terms of long-term pulmonary health, I don't think we're thinking of that because these babies are typically develop high drops and die. Like they're so sick. We're just trying to get something in the short term to get them more stable and get them a little longer gestation. But it is tricky.
Yeah. So Rachael, the word phenotype and its relevance to different circumstances is something we talk about every day. And if you talk to neonatologists and you ask them about functional pulmonary atresia postnatally, you will get blank faces. Most people, it's like something they've never heard of. Mm-hmm. And if you actually look at the literature, there's very little published on, does this correlate exist in actual babies? And I'm just curious to know in terms of, what have you learned as a new faculty about this entity? And secondly, giving indomethacin in postnatal functional pulmonary atresia, good idea or bad idea?
Yeah, great question. I first want to just give the caveat. I am a neonatologist and hemodynamic specialist. So I'm learning it. I loved this talk, and thank you to Shaine who's speaking up and giving us so much fantastic information. I think I got on here. I see a lot of our fetal consults, but this has just been wonderful. So thank you for letting me be a part of it. And I do have a follow-up question actually to Shaine and Amanda also later. But to Patrick's question about the functional pulmonary atresia, and this is in the setting of like normal, otherwise cardiac anatomy, it is something that we see, I would say rarely, Patrick, but we do see that in some of our, probably more commonly in our preterm, early transitioning babies with severe, profound pH and typically some degree of accompanying cardiac dysfunction. And those are the kids, you're doing your, in my case, my functional scan, then you just see this little blip with like no outflow. It's terrifying. I think the first thing from the RVO, and I think the first thing is, yes, ruling out structural cardiac disease. But it like Patrick is saying, we do see that entity in our small babies. And I think being mindful of like making sure that we're understanding the underlying etiology, because as we've been alluding to in all these patients, being mindful of what direction of flow you're supporting and why, and whether or not you need to keep a duct open or not. That's going to be based on what I think in these cases underlying physiology is. When there's univentricular cardiac dysfunction, I think that's very reasonable to maintain ductal patency, much less giving, as you were saying, Indocin would make me a little bit nervous. But I think we're mindful in those patients to just do things that would augment pulmonary blood flow. So judiciously using pulmonary vasodilator therapy in the right scenario and supporting with low-dose inotropy. But it is something that we see and have managed here, and I agree, it's not something that's widely reported. I think there's a case series coming, though.
Yeah, I'm curious for Shaine and for Amanda, because basically on a classic echo, you'll have an open duct with a left to right shunt. And the RV may be normal, may not be normal, but you have massive TR, massive right to left atrial level shunt. And where we see this is you put a Doppler into the main pulmonary artery, there's no blood flow.
Mm-hmm.
This is a purely duct dependent circulation. I'm just curious to know, is that something that you guys see? We see it maybe once or twice a year, and they require pulmonary hypertension care. Maybe start with Amanda.
I think we very, very rarely see it in a structurally normal heart. I know I've seen one of your cases of a functional pulmonary atresia. So I think that entity of the structurally normal heart, unless there's very poor RV function for either a or a fetal ischemic insult or something else that caused severe RV dysfunction, it would be very unusual for us to just see the functional pulmonary atresia. But I do think that as a cardiology group, that is something that we see enough and recognize it as high afterload on the sick RV with a lot of TR, where the afterload on that right ventricle, it's way easier to go backwards than it is to go forwards, and that's where the blood goes, and so the RV doesn't eject. And that, as opposed to, and because there's no antegrade pulmonary blood flow, you will have left to right flow across a PDA, which I think in a lot of situations in the NICU, a big duct with all left to right shunt means get rid of that duct. It might cause problems. And the first thing that a group of cardiologists will say in the setting of functional pulmonary atresia is start nitric, because you have to drop the PVR. Yes, you may. And in the really sick, especially small neonates, I think you have to be really on top of it, even more than we necessarily do in our full-term kids, because then you could very quickly end up with a low PVR, big duct, a lot of pulmonary overcirculation. But gradually the RV will hopefully be able to then eject against the pulmonary vascular resistance, and then you can close the PDA. So I think just a different mental model at which we come to that left to right duct. And now knowing functional pulmonary atresia, I think we do have to think about it differently, but it's very interesting.
Yeah, I think as you go back to physiology, a lot of people forget that pressure is determined not just by resistance, but by flow and atrial pressure. And if you lose flow, you'll also have low atrial pressure. So now you may still have high pressure or high PVR, but it won't be super systemic because the other components are missing. And these cases highlight the importance of physiology. And the scary part is, at least from the cases we've seen, they don't all have RV dysfunction, and then how do you diagnose it? The only way we see it is when you Doppler the main pulmonary artery. There's basically no effective output through that. So anyway, I just thought that was an interesting paradigm shift to something that, you got a similar type scenario, but its relevance in the fetus and its relevance postnatally is different. So I don't know, Shaine, if you have any comments you'd like to add to that.
Comment, I think we have to be really careful because we definitely see circular shunting and functional pulmonary atresia in the neonate as well, and where it's imperative to close the duct. So we have to, I think I've maybe seen it once ever where it's not in the setting of RV dysfunction, where it's just really high PVR, and that's where we basically see complete right to left shunting of the ductus and systole and diastole. But almost always it's because your RV pressure has equalized with your right atrium. So your diastolic and systolic pressure of the RV is now like 5. So it's lower than the diastolic pressure of the pulmonary artery, and then and usually it's in the setting of PR, of pulmonary regurgitation, and that is super bad. So if you keep the duct open, you're allowing the circular shunt to continue. So it's when you see functional pulmonary atresia in the setting of pulmonary regurgitation, that is the circular shunt that we see prenatally and postnatally. And we've had it happen a number of times that functional pulmonary atresia is red on the chart, and people who start prostaglandin, who are like covering or on for the weekend. But if it's in the setting of TR and even if there's no systolic dysfunction, it's basically the RV has normalized with the right atrium, and you're getting a circular shunt. So the first thing to do is to get rid of the duct.
Certainly, if there is.
Discontinue that, yeah.
There are two things. Absolutely.
Yep.
So as long as people are paying attention, if there's PR, you always want to close the duct. And then I guess if there's not PR, then it's a different situation.
It's a different story.
And then it's not like a spot of
seen
trivial. It's not a spot of trivial PR, but
Moderate
like
PR.
your duct is pouring.
Yes, right, back into your
into your RV. Then the duct, there's no.
And that can be in the setting of high PVR because it just goes to the RV, not to the lungs. And so you're exactly right. We would close the duct with certain nitric.
Yeah. I think the bottom line is, making sure you have blood going to the right place.
Yes, right.
I think at the most simple level. Faith, do you have any other question, or do you want to? There's one in the chat.
Let's have a quick look at the chat. So I think there was a question from our audience about maybe Amanda, you could talk a little bit more, or can explain a little bit about the circular physiology in the context of Epstein's anomalies. I think the question there is just how does blood flow from the aorta to the high pressure pulmonary artery in these babies?
Epstein's, yeah. So I think, and Shaine can, as the fetal person, can correct me if I am wrong, but essentially, if you have the way that your pulmonary artery blood flow is supplied in cases where there's inadequate antegrade pulmonary flow from your right ventricle into your pulmonary arteries. So in your more severe forms of tetralogy of Fallot, pulmonary atresia, or in severe cases of Epstein's anomaly where there's not good antegrade flow from either the smaller, poorly functioning right ventricle into the pulmonary arteries, there's sort of there's like a space for which blood flow to go from your aorta across your PDA and supply pulmonary blood flow in utero. And if that doesn't happen, then you actually get no more of that pulmonary vascular growth in our favorite cardiology, no flow, no grow paradigm. So you're actually dependent on reverse flow in your PDA to supply your pulmonary vascular bed in utero. So those are situations in which we see reverse flow or bidirectional flow across the PDA, even though we do know that the PVR is high in the unexpanded fluid-filled lungs of a fetus.
And fun fact, you're exactly right, is that prenatally the duct should be right to left, right? Because the lungs are not inflated. And if we see a left to right ductus in utero, we know they're going to be ductal dependent for pulmonary blood flow. Like that's our sign that they need PGE. So we are either ductal dependent for pulmonary blood flow or ductal dependent for aortic blood flow. And the left to right ductus in utero is universally present if you need PGE for pulmonary blood flow.
Rachel, I have a question for you. Can you maybe talk about, with your role in kind of the high-risk fetal stuff, both clinically, academically, the role of the interprofessional team in supporting the care of these babies, and then secondly, I think this is something that we just have not really engaged with enough. Is when I look at a lot of the kind of the fetal imaging, fetal cardiac imaging, and looking at the measurements that are done, the follow up of those children postnatally, and how potentially bridging the world of the neonatal hemodynamics world and fetal cardiology world together, maybe synergistic academically.
No, absolutely. I appreciate that question. I think my cardiology colleagues probably, hopefully will feel similarly to me in that collaboration is critical, especially antenatally. So I see so many of these families in clinic, and whenever possible, I'm doing it along with my cardiology peers. And I know that's variably able to be set up at different centers, and everyone has different models, but especially, you look across, at least in the United States, there's various models for how we're caring for these patients postnatally, and so that there's the antenatal time, there's delivery and that immediate transition period, and then there's the period post pre-repair. And I feel like there are different models at different centers. In our center, for instance, our babies do go to a CV ICU even pre-repair, but many of our NICU colleagues and partners around the country are caring for those patients pre-repair, and having that close collaboration and model between the cardiac intensivist, the cardiologist, and our neo group, I think is critical to provide obviously the best care postnatally, but the prenatal piece, like you mentioned, having consultations, group consultations, having shared expectations is really helpful for our families. And we've gotten that feedback from them too. And we're kind of going through those growing pains right now in our own center as we're trying to involve our CVICU team and more in those conversations. But I'm sure that Shaine and Amanda may have things to add on that side of the conversation too.
Not really. I mean, I agree. I think the multidisciplinary prenatal care plan, and again, not a fetal person, but they definitely have multidisciplinary meetings. Everybody meets with parents ahead of time, ranging from the cardiac surgeon to the cardiologist or neonatologist or fetal surgeons if there's other abnormalities. Palliative care, everybody is involved really pretty early on so that there can be a longitudinal relationship and just new questions arise and things change. And there we have a kind of a roadmap through fetal life, sometimes very involved delivery plans for if this, then this, if this, then that, and how quickly can we get somebody to their definitive treatment if needed. And then our babies also go to our cardiac ICU with a neonatology team that consults and is present on rounds for all of our neonates. And the collaborative rounding, I think, is very helpful for the parents and for the patient's care for sure.
Yeah, and just agree. We have neo consults ahead of time. Our sickest babies do go to the cardiac ICU. Our babies who don't think need neo surgery go to the NICU. We don't have NICU round on every baby in the cardiac ICU. That would be amazing. We do have our trainees rotate through the cardiac ICU, and we have some liaison attendings from the NICU that are up quite often, and we can call at any time. And if we have a very preterm baby, we will have a permanent NICU person during their course while they're premature come up and round as a consultant. So, but we absolutely love having NICU involved longitudinally, prenatally. Obviously, they're the ones at the delivery, and postnatally, it's really important. We also started a class several years ago where the parents all come meet, and it's the babies expected to go to NICU and cardiac. It's usually about 2/3 cardiac babies, 1/3 other anomaly babies, but it's usually about 8 or 9 families. We do it quarterly, and they have this all day kind of, but they all get to meet each other, and they meet nurses and parents, and they go through these really practical things. It's like how to parent in the ICU, but it's like, what's a monitor? What's a NICU? What's an attending? What's a charge nurse? What's an NG tube? What's a pump? All these things that we don't we're not necessarily doing in our fetal consult. And I used to be involved, and now it's all nurses and parents. And I think it's people really take to it well, and they get a NICU tour and a CVICU tour.
That's a great idea. I'm writing this down. That's awesome.
Yeah.
You should publish that. That's really good.
We do need, I think we're finally going to write it up. We actually came to it bilaterally. I was doing a public health course, and we had to interview a patient about what they didn't get. And I interviewed a patient, and she's like, we need more talking. We need more practical tips. And then the woman who's now the head nurse of the entire heart center, the most powerful nurse in the hospital at the time, was our field coordinator. And she got the same complaint from a family and started developing this curriculum the same time I was. And we merged together and developed the class about 6 years ago. So.
Do you guys find something, you were talking about that and what you're able to cover in a consult? That's something that I still struggle with. You're trying to, especially for families that have limited medical background and knowledge, trying to consult on the complexities of a CVICU course or a NICU course or whatever it's going to be, bringing them to what does informed consent mean? And I was watching that video that our speaker, which was amazing, was sharing on the fetal surgery. I was oh my gosh, how do you consent and talk through all of this? But same thing for your courses. I mean, for how do you, it's hard, and that's a struggle that I'm continuing to learn and work on. But I don't know what you guys think.
No answers. It's hard. We just keep having them come back. We do multiple consults and see what they need, but we still not we usually have an hour or maybe an hour and a half, and we still don't get to the nitty gritty. They really want to know the heart stuff from us, the surgery, the long-term outcomes. And then I realize we're not talking about don't buy baby clothes because we're going to make sure your baby is naked, but you can bring nail clippers, the practical things, we kind of loosely talk about breastfeeding, but not in depth. So that course has the lactation expert comes and talks, and, just they actually show an isolette, they show a monitor, those little practical things that I just don't think we have the time for.
So let me just take the conversation in slightly different directions. We've talked a lot about the really sick baby, the really complicated baby. And I'm going to defer this to Rachael and to Amanda, perhaps. But a lot of the patients we see in the NICUs across the country, across the world, the growth-restricted infant, the twin transfusion infant, the infant diabetic mother may have very significant heart disease, in the postnatal periods, heart dysfunction, obstructive outflow tract disease, et cetera, and I worry that perhaps those patients don't get the attention needed, long term. We've got very clear follow-up for children with major congenital heart disease. We've got great follow-up for babies who are extremely premature. But oftentimes that follow-up, is limited to neurodevelopmental outcome, et cetera, et cetera. Is there something missing here with these children in terms of what their follow-up should be in terms of risk? And then the related question is, how do we enhance that academic relationship between people who are interested in these babies postnatally, the hemodynamics people, and the fetal cardiac imaging people to actually have more clear studies looking at the measurements that you see postnatally versus antenatally, and are there predictors of outcomes, et cetera. So it's a lot of questions, but I think it's a really important topic that sometimes perhaps falls between the cracks.
Yeah, I'll jump in first and then I'll let Amanda take over. But just the question of risk stratification and what we can get from fetal imaging, I think, is a really important one. I think that we don't have enough data, but there are some markers and things that we can follow and trend within specific populations helpful, but I completely agree it's an area ripe for further research. Unfortunately, I think same answer for the long-term longitudinal follow, because we know, like, our growth-restricted babies, there are data to suggest that long-term they have increased risk for cardiovascular, adult cardiovascular complications, blood pressure problems, events. Like that's true, but what that means for their frequency of follow-up and who would do said follow-up too is hard, because if we're talking about outpatient follow-up for that's like partnering with our cardiologist, but then you're talking about babies maybe, with completely structurally normal hearts, but they were growth restricted or they were a little bit thick and it's looking a little bit better towards discharge. That piece is hard. And then you also have to think about too, like, this sounds bad, but the cost of that medical care and assessment and like what people are willing to do and follow up and what it really will impact and mean. I do think that you're right, though. It's going to be between our cardiology partners and our neos, and maybe hemodynamics can kind of bridge that and be a part of it. But it's great questions.
Yeah.
Yeah.
Amanda, any additional thoughts?
Not really. I think Rachael brought up some very good points, and I think the questions are interesting. Even in I bridge the gap a little bit with pulmonary hypertension as a clinical cardiologist, and then working closely with our BPD clinic in the outpatient world, and became aware not that long ago that our cardiology fellows assumed that long-term pulmonologists were ordering echoes to follow up pulmonary hypertension in older kids. And I was like, absolutely not. Like, they think that cardiology is still following these kids. And so we, for at least that population now, follow up at, even if they discharge off oxygen and are doing well, follow up at a year. And then a preschool, kindergarten, school age one, just because there is so much evolving information about long-term effects of cardiovascular risk and early heart failure and all these things. So it doesn't seem fair. I mean, we're not going to be like, your child's in the NICU. They might have a heart attack when they're 37. Like, that's not the right time for that. But like having some very infrequent longitudinal follow-up so that we can stay apprised of what's coming in the world of research. And as we learn more about these very early gestation and growth restricted babies make it later into life, that I think there's going to be a lot that we learn. I don't know where it lives. I don't know. It is not of greatest interest to congenital cardiologists to follow the structurally normal heart that may or may not develop mild cardiac dysfunction in the future. Whether the heart failure teams are like so incredibly big, I don't know where it's going to live, but I do think there's a gap both in knowledge and in likely need as we move forward. And I love the nuances and the subtleties of cardiac function and structure. So happy to work with anybody who wants to continue to follow those kids longitudinally.
I wonder, prevention is growing as a subspecialty in pediatric cardiology, and they're following long-term people with like borderline hypertension, obesity, Kawasaki from 10 years ago. And so they're following a lot of the subtle markers, like carotid thickness and LVMI to the 2.7, like the more mild LVH parameters. And they follow a lot of these subtle vascular markers. And that might be, I don't think we have a long-term follow-up place either, but that might be the right place for them to fall. More and more places are getting prevention programs that are not. You're right, most cardiologists are really obsessed with congenital heart disease, but that is a group of people that are really interested in the subtle long-term markers and vascular health.
Yeah, I think that's actually a great point.
Yeah, and Shaine, your comment there, just one about cardiologists are obsessed with congenital heart disease. This is why the field of neonatal hemodynamics has developed, because of that. But it's interesting because, we're starting to see with a lot of rigorous follow-up on echo that prior to discharge, these two phenotypes of a left heart phenotype with hypertension, a right heart phenotype with pulmonary vascular disease, which mirrors what are seen in the adults. And it was only serendipitous through a study on breastfeeding of, ex-preterm babies that this discovery happened, that these hearts were abnormal. And, one just wonders, should the starting point be with people like Karagoss and others who are adult cardiologists to actually ask those questions? Were you born growth restricted? Were you born with twin trend? Maybe that's where it should start and go backwards as opposed to going forward. But I think collectively there definitely is a gap there, which is, important and certainly is interesting. So.
Yeah, I guess maybe even measuring a blood pressure in the follow-up clinic would be a good start. Yeah.
Yeah. Any other questions for us?
Just not from the Q&As. Looks like there are just a couple comments. I think the audience, similar situations where there are, the loss in the ether post-discharge. Certainly a lot of people are interested in this area, and lots of connections to be made with different specialties moving forward. But yeah, a good research field for sure.
Okay.
I don't know. There's long-term neonatal, the neurodevelopmental clinics through the NICUs. I don't know if there's ever non-neurodevelopmental recommendations that come out of that. I mean, you need a full, what we're looking for is a full function assessment with strain and cardiac chamber sizes and things, not just it overall looks generally good, but I don't know if there's a way through that avenue for any sort of recommendations for follow-up to continue. But
it's good that we're starting to talk about it, because that's always the start, and then academically starting to study it. I think that's where there's a gap. I think, research-wise, developing programs to study like the Muscatine type study, looking at children prospectively potentially is the way to go. But this has been a wonderful session. We're at 2:10. I think we should probably wrap it up. And thank you to Lindsay. We hope you're sleeping peacefully in Bangkok. We thank you for your presentation. Thanks to Shaine, to Amanda, to Rachael for being incredibly thoughtful panelists. I really have enjoyed the discussion, and thanks to my co-moderator, Faith. So we will let everyone go, and wishing you a wonderful and happy holiday season. So
happy holidays. Thank you so much for the invite. This is wonderful.
You're welcome.
yes,
Thank you so much.
Thank you. It was great.
Bye-bye.